Good afternoon, ladies and gentlemen. Welcome to the HEAD Foundation. I'm C.D. Liang. I work for the foundation, obviously. For those of you who are new, we have about 200 individuals sign up on the online session, so we have online audience on Zoom today as well. For those of you who are new, HEAD Foundation is a foundation set up in Singapore about 10 years ago. We focus on supporting projects in healthcare and education. Our scope is to, or rather our mission is to improve life in Asia, especially in the Southeast Asia region. And we try to do that by offering grants for projects in research and also on some of the social work in different countries in the region. A bit of a house rule before we begin. Please turn your phones to silent. And we will have two speakers today. Each of them will speak for about 20 to 25 minutes. After that, there will be a Q&A session. Please save your questions for the Q&A session at the end. For those of you who are online, you can type your question on the chat box on Zoom, and someone will pick the interesting question to ask our speaker and our moderator on your behalf. Let me give you a bit of background on the series on aging. We feel that this is an important issue for society and our community. And it is also part of our mission to create awareness and also share knowledge on important issues. As all of us know, the population is getting older. And we also know that being in Singapore, we have some very good policies, especially in the recent years, to try to mitigate the issue of aging population. Since we also have audience from the region who are online, so we also want to take this opportunity to share some of the good practices and policies in Singapore so that we can learn from each other in the region. We also have in Singapore a lot of good doctors and healthcare professionals in our community. So we decided to invite some of them to share their experiences and knowledge with our members, with the audience. There are 5 different parts in this series. Last week we have Professor 𝗂𝗂𝗂𝗁𝗂 and Dr. 𝗙𝗂𝗂𝗂𝘁𝗂𝗂 talk about the mind and the brain related to aging, more of the mental side of aging. Today we have Professor Tay Boon Keng, and later you'll see Professor Lydia Au on Zoom to talk more about the physical and the nutrition aspect of aging. And then later in November, the rest of November and early December, we have 3 other topics. I'm sure you can find all this information on the website. Let me, before I let our moderator, Maleena, Dr. Maleena, introduce our speaker, I'll give you a bit of background on Dr. Maleena. Dr. Maleena is the Chief Wellbeing Officer of a National University Health System. She was trained as a food scientist in King's College London. She got her MBA from the top business school in France. She also has a doctorate degree in education. She's both a healthcare educator and a nutritionist. She has worked in 6 different countries in the last 30 years. She speaks 7 languages. While our doctors and healthcare professionals, nurses, took care of the patients during the 3-year COVID period, she was the one who took care of our healthcare workers and our doctors and nurses. Without further ado, let me invite Dr. Maleena to introduce our speakers.
Thank you very much, CD. Can everyone hear me? Okay, I'll keep the voice at this level for the comfort of our viewers online as well. I didn't expect the CV to come up, but I think I will have to sort of moderate the moderator's CV as well. Thank you all for coming and also to our speakers. We will kick the series number 2 off with the physical aspects of health. The first talk by Dr. Lydia Au will be on falls and frailty. I know it sounds a bit dire when we talk about falls and frailty, but the whole idea is the good news behind it. How do you slow that process down? How do you, we can't completely prevent it, but sort of be aware of what we can do to not have them either too often or not too severely. All right. Dr. Lydia Au, just like Professor Tay, are colleagues from way back, and I know that you will enjoy their interventions today. Lydia is also an old friend from Fong General Hospital, not just in the geriatric space, but also medical manpower. And I know Lydia has gone to the ministry on many occasions fighting for manpower for the hospital. So thanks to Lydia for that as well. And today a shout out to Lydia. Someone in the audience, Ruby Lee, is here. She wanted, I said I'd say hi on your behalf, on her behalf to you, Lydia.
Yes,
I think Lydia is not worried that I'm going to share this fact. She rang me yesterday saying that she wasn't feeling too well and she hadn't tested positive yet, but she has, so for COVID, and she's at home. We still enjoy her presence and her talk from a distance. So Lydia, over to you for a virtual experience. Thank you.
Thank you, Maleena, for that nice introduction. Thank you, Mr. Liang and the Head Foundation for having me here today. It's been great preparing for this talk. I'm so excited, and I really wished I was there personally to speak with you all, to interact. And hi, Ruby. She has heard me multiple times. Ruby and I go a long way back, Ruby, because we actually do adult protection together. And that is another dismal thing that we're not going to talk about today. So I think that, without further ado, let me just share my slides, and then we can have that chit chat a little bit later. Well, you know me, I talk really, really fast. So, if I do talk too fast, I'm sure you can always replay this in slow motion, times -2 or something like that. And you'll hear me speak slower when you replay this. So let me talk to you about F2, because we just finished F1. And it's about frailty and falls, the partners in crime. All right. And somehow my things don't move. Okay. Let me just try that again. It always does that. Okay. So let me tell you a little bit about what Singaporeans are going to be like in 2030. I will be one of those people who are going to be 65 years and above. For all of you, I guess you all will be much younger than I am. I always tell everybody that I'm half a century old, and I'm very proud of it. And unfortunately, right, the number of seniors aged 65 years and above will almost triple to almost 1 million by then. So we have 1 million of our, I won't call it miserable 6 million, that we will have to take care of. And certainly today, we want to learn how to make sure that we don't get to a frail state.
Is that HON?
Now, to give you a little bit of background, all of us are, if you are 0 to 25, 0 to 30 years old, you are doing well. Why? Because you are going to be improving in strength, improving in every aspect of your life. But when you are 30 and you are hitting there, it's going to be a little bit of a downhill roller coaster, right? Okay, maybe not a roller coaster, slowly going downhill. Okay, and by the time you're 80, if we are doing today right, okay, none of us will be frail. So that's what I want to tell you. So maybe just give you a little bit of background on the right side. the box that I'm showing you today shows you that the heart, the lungs, the kidneys, and the way we are actually using up oxygen, they are not going to be as efficient as we age. And that is obvious, isn't it? So if everything ages, then something else causes age, and that is the muscles. And muscle strength, right? Strength, I'm not talking about the actual muscle bulk. The bulk might actually shrink, but the strength does go downhill by midlife, all right? And this actually is because there's a very slow loss of muscle mass, and this is actually called sarcopenia. And actually, before you actually see the muscles being, almost gone, you'll find that the person can experience weakness, slowness, low physical activity, and this can actually come even with exhaustion that comes on before that. And weight loss is actually something that can happen in 76% of the women who were non-frail at baseline. Having said that, I was hoping that I will have some weight loss. For all of you who know me, I'm very plump. And I was saying that, wow, if I could just lose 15%, I'll look fabulous. But anyway, in terms of sarcopenia, we are not going to encourage weight loss at all, okay? A little bit more about frailty. What's the definition? Now, it is actually a clinically recognizable state, okay, of increased vulnerability resulting from aging-associated decline. So everything written here so far says that you can't probably reverse very much of it because it's an aging process, all right? And it's actually across multiple systems like the kidney, the lungs, the brain, all right? And the unfortunate thing is that it decreases the ability for us to cope with the everyday stressors and the coping strategies that the body used to have when we were younger is starting to be compromised. So that's what frailty is all about. So I wanted to show you a little bit of pictures. Pictures, speak 1,000 words. So this will be a severely frail elderly lady. We do still see some of our folks around, which unfortunately do look, the phenotype we call it. We do see our folks like that still in Singapore. And I think in most parts of Asia, if you are traveling, you still see people in this situation as well. What we want to get all of us to is this way, all right? Fighting fit, so to speak. Now, in the local data, and this was collected over the last few years by the doctors who do a lot of the frailty work, the range actually is fairly high, 5.7% to 6.2% among our older adults are actually frail. In terms of race, our Indian friends unfortunately seem to be a little bit more frail compared to the Chinese and the Malays. And for all of us who might have diabetes, that situation again increases the risk of a person being frail. And I actually practiced in the hospital since 1992. I've been a geriatrician since 1998. And to be honest, I only see the tip of the iceberg, and my whole life is colored by very, very frail people. So I'm actually extremely excited when a younger old person walks into my clinic and say, wow, this is my opportunity to make an impact. So I recently have a patient that came. She's only 74. She's only 31 kg. And I was like, wow, this is my time to intervene. So instead of talking about how we should treat her this and her that and whatever, all I did ask the family was, is there any chance that we can feed our patient a bit more and make her fatter? And they asked me, so Dr. Au, how fat do you think my mom should be? So I did the BMI calculation. I said, she's 31. Her actual weight should be 54. I think the patient said, oh gosh, I'm going to be a whale. I said, no. You just need to be 40 and that will be fine. We are halfway between there. So let me tell you that a lot of our younger olds have all that opportunity to increase the ability to fend off sarcopenia, to fend off frailty. And to be honest, really for us who are hospital physicians, it is such a joy to actually sometimes do preventive medicine. So what are the contributors of frailty? This is only a picture, but I just want to let you know that what we see is physical frailty, but hidden in society, there are social frailty. People have got difficulty interacting, they have no social resources, there are social isolation. And there's cognitive frailty, where there's a decline in the mentation, the way that the person, the word we are always worried about is dementia. So these are actually different types of frailty, but the one that's so easy to look at is the physical frailty that I just showed you. Now, this was maybe all of us who are perhaps more graphically inclined, this is how I would have put sarcopenia and frailty in the same picture. So if you look at early loss of muscle mass or age-related loss of muscle mass, it then makes the person more and more, weak, all right? And then you walk slower. So, if you can run after the MRT train, no, just kidding. If you can walk really fast, that is good gait speed. Then maybe you're not frail. But if you start realizing that you are actually walking much slower, you realize that actually perhaps, sarcopenia is setting in. And in advanced sarcopenic states, okay, where the frailty strikes, there will be fatigue, again, weight loss. And then with all that, the person says, okay, let's just stay at home. And that actually makes it more detrimental. And the person becomes socially isolated, becomes depressed, and then cognitively impaired. So it is actually a whole range that finally accumulates to frailty. Now, I wanted to say why falls. Falls actually is one of the early presentations of a frail person. And falls being something that nobody wants to experience because it really can cause fairly serious harm. So what happens in falls? Falls happens when balance and gait actually becomes a problem, and is actually a major feature of frailty. Now, for a person who is starting to be a bit frail, just a little minor illness can already cause you to be off balance, and then you're off your feet and you fall. Now, in severe frailty, you don't need to be sick. Your vision, okay, don't say the vision, the balance, the strength, none of it could be consistently depended on, all right, for the person to be able to keep upright and to navigate safely on even flat terrain. So that is where severe frailty happens and falls happen. And when the person keeps falling, there's a lot of fear, because when a person falls, many things could happen. For the people who know me, I actually have been working in the orthopedic wards for the last 20 years. I'm actually a hip fracture crazy. Okay, I'm not crazy. Hip fracture orthopedic geriatrician. I look after all fracture hips. And this is what I see as the end stage of very advanced frailty, where people fall, they fracture their hips, and they get admitted for surgery. And it is a very long process to get them back on their feet again. I'm very passionate about talking about frailty because, to be honest, the great news out there is it can be reversed. Okay, so I would say that if a person is very advanced, so let's look, if you could remember that picture that we had of a very frail little old woman and a very fighting fit older man. If the little old frail woman comes in, I wouldn't dare promise her I can reverse. But if it's a fit older man that could have fallen and even fractured, I would say, yes, I'm going to get you back on your feet and you're going to be running again. So when we see a person who is very frail, there are still many things to intervene, but it might not be totally reversible. But if the person is pre-frail, meaning that, it's marginal, there is every chance that we can do much more to keep them fighting fit, all right? And the evidence is that if we intervene early, physically, nutritionally, and cognitively, meaning that we keep the mind active, there is evidence to say that this kind of interaction and interventions can persist over an entire year, okay? And the person can continue to improve when there's a lot of motivation to carry on. So I wanted all of us here today in the audience, the reason why I always say that I'd rather have a face-to-face is because then I can eyeball all of you and say, wow, we have a fighting fit audience here, but obviously I can't see you at this moment. But I'm sure for you all to be there, you all will have been fighting fit, I would want to say, right? So maybe just a quick understanding of our national program that is coming on. This is what we are going to use, and it's very pictorial, and it's very self-explanatory. For all of you who are very motivated, You can Google that on your handphone today. It's called Clinical Frailty Scale. We are going to use this to, in a way, categorize all our older folks, 65 and above, when we have to interact with them in the medical world. And we want to stratify them because, in a way, that helps us to then see what we need to put in to encourage our older people to either get better or to mitigate any of the adverse events that could happen, and we can anticipate what we need to do for them. To tell you what a geriatrician does, okay? Any person that comes to a geriatrician, we look at all sorts of things, but the 5 main things are up there: the medical condition of the person, the mental health, how we are able to interact in the environment, the functional capacity. We actually are more capable than normal, okay? We are social workers at heart. We ask about social circumstances. We ask about who supports you, who's the carer, how much money you earn. Okay, I'm a pure kepo. And finally, we are also very environment kepo as well. We are asked about what kind of place you stay in, you know, how can we improve it? There are many, many schemes that we know about. So this is what we actually do as a geriatrician. We wanted to make sure that in all aspects of an older person's life, we want to take care of it, because our government has actually enabled quite a few things, and we want to make sure that we open that access to all the Singaporeans to actually have to see a geriatrician. For fun, I thought that this was very pretty, but basically, basic activities of daily living is just all the function you require just to survive at home. So if a person loses the basic activities of daily living abilities, this person will need care. So anybody who has difficulty eating, difficulty getting out from the bed, difficulty getting to the washroom and cleaning themselves well, the person will need a carer. So even in all this, we will look into, because it does matter a lot to the patient when he needs care. So let's come to the things that you and I can do better. We are going to look at interventions. This is courtesy of Abbott Industry. I love the picture and how it represents how we should actually approach frailty. Basic nutrition forms the foundation because that is easiest to do. I'm sure you, all Singaporeans in the world, whatever form, they love to eat. So basic nutrition is where I would like to start. Exercise is the top of the game. Actually, as I keep saying, if you know me, I'm plump. I'm a big fat couch potato. So I'm not preaching what I'm teaching you. So I'm glad I'm actually on Zoom so that you can't see the rest of me. All right. Okay, let's talk a little bit about what kind of nutrition is the nutrition. It's actually about protein. All right. And it has to be good source protein. Complete amino acids. Okay. Don't ask me how complete is complete. That one, I am so glad Maleena is next to me. Oh, okay, next to me on stage, right? She will tell you all the complete proteins. Me, myself, and I can't remember any of them. But having said that, right, the recommended amount is 1.2 grams per kilogram body weight. So if your 12 times table is as poor as mine, I will always say at least hit 1 gram per kilogram body weight. So for auntie here, sitting here talking to you, I'm more than 70 kg. So I have to eat 70 grams of protein. Wow, that's a heck of a lot, right? I would say. Having said that, right, you don't gobble up all 70 grams at one sitting, okay? So don't come and say, oh, you know, Dr. Au says I must eat protein. Go to some big steakhouse and order 5 slabs of steak and eat them all at one shot. It's not going to help you. You need to divide the protein into separate intervals so that better absorption happens. All right. So the 5 steaks, right? You can eat one, the next 4 you give to me. All right. So this is how 20 grams of protein will look like on your plate. I thought this was good to look at because it's Asian diet. There's a bit of chickpeas on the left. There's some egg whites. There's a chicken breast there. Usually the recommended size is about a palm size. So if you have huge hands, you have a bigger piece of chicken meat. Actually, chicken breast is one of the best protein, I would say, because they have very little fat. So the whole chunk is actually full of protein. Of course, you don't take the skin. And then there's tofu. So a little bit of product endorsement. We use a lot of Ensure, so I thought I'll put a can of Ensure there. It does contain protein, but actually there are better source of oral nutritional supplements that actually has a lot more protein than Ensure. Now, I know that a lot of our audience are Asian. So I thought that this might be actually helpful. I took this from the dietitian in Fong previously. she gave me this as a way of gauging how much protein my patients take. So I will have probably ordered 10 tubs of ice cream for myself because each tub is only 3 grams. A bit of soybean milk can only give you 4.5 grams. And actually a tuna sandwich can give you 14 grams of protein. But actually, to be honest, I'm not sure whether Asian people eat tuna. I mean, I love raw tuna like sashimi kind, but you know, the tuna in a can. Some of my Asian or my Chinese patients say, wow, the smell is quite something. Well, I don't know. I love tuna myself. So, you know, maybe you can try an egg sandwich. Now, so that was nutrition in a nutshell. I want to talk a little bit about exercise, not my favorite topic, but nevertheless, this is something that is even more important, to be honest, because it maintains and it improves your muscle function. Now, there are a few types of exercises that we recommend to the older person. Aerobic exercises is actually really for the heart and the lungs. What is actually more important for frailty and falls prevention is actually resistance exercises. And you have to do that at least twice a week, you know. I don't know how much twice a week means to you guys, but twice a week for me is like a lot because I don't even do once. Anyway, I will show you a little bit about what resistance exercise is all about. And finally, power training. I think for some of us in the audience, you might still be going to the gym and all that, and please do carry on because you're probably one of those fighting fit when you hit 85. So I thought that this is something that I can encourage myself. It's resistance training. You can use your own body weight. If you would like to look at the picture on this arrow, it is actually a sit to stand exercise, cheap and good, because if you're heavier, you're doing more resistance because you're using your own body weight, all right? So resistance exercise is the exercise I would say you should do for muscle strength and falls prevention, all right? And remember, it's at least twice a week. Now, if you're doing sit to stand, I always tell my patient, including myself, if every day before you eat your lunch, you do sit to stand 10 times, you eat your dinner, before you do that, you do sit to stand 10 times, that might actually help with resistance exercise, resistance, so to speak. The other exercise that is of resistance value is the mini or half squats. Actually, I wanted to make a bit of mention about the chair that this lady is using. I would suggest that you try not to use this kind of chairs only because the chair might tip backwards if you lose your balance. But if you have a very firm chair or you're holding on to a table that doesn't fall on you, that might be a bit better if your balance is a bit more dodgy, right? But if you have excellent balance, then nothing to say. Then this is a good exercise. Now, balance training is the other thing that we do for falls. You walk with your heel to toe, toe to heel, you know, like if you're drunk, that is actually balance. The other thing is to stand on one foot. And of course, if you stand on one foot and you're one of those people like me who is like a 𝗛𝗚𝗨, right? You want to have a table a bit next to you so that you can hang on to it in case you tilt over. Now, I wanted to bring now something that we have seen in the community, which I really do hope that some of you might utilize. This is gin tonic, all right? And this is actually a specialized modularized exercise program. And you can look it up on the internet. And if one of those programs are near you, I would seriously encourage you to consider. I wish my mom could go for it, but mom is 88 years old. And no matter what I ask her, even sit to stand, the answer is, nah, I'm already 88. Please don't be like my mom. I have been scolding her until she says, Lydia, can you please don't call me? Because every time you open your mouth, you're going to scold me. Now, gin tonic is also called Uncle Auntie Gym. All right, and it's actually designed for our pioneer and medical generations. Of course, no, even if you're not pioneer and medical and you do want to go for it, I'm sure they will want to admit you, all right? The other side that you will want to consider is Active SG. I know that some of our audience are not from Singapore. I apologize. I am actively trying to be a good Singaporean doctor to try to also advertise a little bit of the work that our Health Promotion Board and Singapore government has been doing to make sure that our older folks are actually getting healthy or keeping healthy. It's HPB's 7 easy exercise to an active lifestyle. Again, if you look at the exercises, some of them I've mentioned before. Okay, sit to stand, you know, half squats. So please, by all means, you know, they're all on the internet, easily available. Please have a look at them. And finally, falls prevention. I never not say, please, elder save your home. All right. This is a checklist easily available anywhere. You can Google it. Okay. Make sure the house is safe for our older folks. I know that some of our older folks are hoarders. We actually have a small little passage that goes to the toilet, and that's about it. So these are very unsafe environments for those people staying with them. A lot of the times, we want to make sure that the environment with grab bars, with proper lighting, all these are necessary. There's an ease program that our government has that makes the toilets safe, the grab bars are being installed. So a lot of these programs are easily available for the people. And I do hope that when you have heard me talk about this, to Google it, to get it on the internet, the information, and you know, to elder save and elder proof the house. I thought to complete the talk, this is Asia Pacific Clinical Practice Guidelines for the Management of Frailty. The strong recommendation is, of course, to use a good measuring tool. This is actually for doctors, but I thought that it's good to just put it up here in case, you know, this deck of slides go out to you all. Then you might be able to see what was recommended to the doctors and what to do for our patients. Finally, you know, long ago as a young doctor, we always say very easy, please, when the patient comes in, complete rest in bed. But now you and I know that resting in bed is really not it, because muscle strength is really going to go. And truly, even if it's chicken rice in bed, that's not a goal either. I love chicken rice, but in bed or otherwise, it might not be that healthy if you take the skin. With that, I should stop sharing, and I finished my talk. Over back to you, Maleena.
Thanks very much, Lydia. I appreciate the fact that in spite of COVID, you're hale and hearty as far as we can see. And
I sound like a frog.
a happy frog anyway. And the red is very becoming.
The red frog, yes.
I did see a raised hand. I don't know if it's a Mr. or Mrs. H.H. Tan. Was that a mistake, or did you want to ask a question? No? Okay. All right. So I don't know if anyone in the audience at this stage has anything to ask Lydia. You have an opportunity around, I would say about 5:30 as well. But if you have any questions that you're dying to ask Lydia.
By the way, I apologize, I overran a bit.
No, not at all.
Maleena, can I ask a question?
Yes.
Am I allowed?
Yes, you're allowed. Yes. Well, you got the mic as well.
Yes. So Lydia, can I ask you a question that I'm glad to note that you are passionate about sarcopenia, just like I am. But you know, unlike osteoporosis, which is the other side of what we see as orthopedic surgeons, there's the muscular side and there's the bone side. For osteoporosis, you can measure it quite accurately, and you can follow it up accurately as well. We have this bone BMD, bone bone density.
Yep.
What do we have in terms of sarcopenia that we can put it a figure?
Actually, right, amazingly, Prof, amazingly, the same BMD machine actually measures muscle mass. I should have put up a picture for you. There is actually, I can't remember how to pronounce the entire thing, but it's actually the same machine measuring the amount of muscle mass we have in our body. And in fact, we do that as studies. For all of our research, we actually send these people to the hologic machine to get their muscle mass measured. So there is an objective, quantifiable way of measuring muscle. There is, Prof.
I'm not so sure that it's completely true, because I think it's a proportion of what the bone mass is, and it's derived as a consequence of what your bone density is.
That is I think there's I will try to bring up one of those pictures later if I have the chance. It does give you a fair estimate, according to my radiologist colleague, okay, about the amount of muscle mass the patient has. And I guess in a way, that's the only thing we have in today's science. I don't think I know of any other techniques that measure anything more than what I've just described.
I don't want to prolong this any longer than I should, but can I just be tempted to ask you one more question to follow up on it?
Okay.
You know, in bone density, again, comparing with bone, we have quite effective drugs. Very effective, in fact. In fact, they're getting better and better.
Oh,
And
totally
they're getting
agree.
shorter and shorter need to treat. But in sarcopenia, in muscle weakness, what can we offer the patients? Say, take this pill, and in 6 months' time, you'll be like Superman.
You wish. I think you should have watched Avengers, right, where Chris got puffed up as Captain America. But actually, maybe the other way of looking at it, Prof, would be that I would say that all of us have the correct thing to do. We have protein, good source protein, and that doesn't even need a prescription. If we get good protein and we do exercises, the cure is, okay, inverted commas, the cure or the prevention is in our own hands. So that's why it's actually important to get the message out there.
Thank you.
Sorry, Prof.
Thanks, Lydia. Thanks, Prof. On the subject of proteins, just now Lydia was mentioning, right? There are about 20 amino acids, but 9 of them are essential in the sense that they're all essential, but 9 we can't produce them. They come from our food. So we have to ingest that form of protein. Yeah, they've got long names, leucine, tryptophan, all those, methionine. You can just Google, you'll know what they are. And for any reason, you know, even for vegetarians, if they're not going to have meat or fish, eggs are a very good source of protein unless you have allergies to eggs or albumin, tofu, tempeh, dairy products, so yogurt, cheese is also protein rich. It comes with fats, but again, like Lydia said, it's the quality of the fat. Don't worry too much, and the quality of the protein. And if you're going to do resistance exercises, that what you ingest will then translate into muscle mass. All the muscle fibers, actin, myosin, all the things that you need to build those chains of muscles up. Yeah. So, Prof, your turn. Okay. So I'll let him come comfortably sit in his chair before I proceed. So Professor Tay Boon Keng is Emeritus Consultant at the Singapore General Hospital, orthopedic surgeon. And I suppose if you've seen on the website, it's a very, very long list of accolades for Professor Tay. I leave you in his good hands. He will be talking about novel solutions to aging knees, our joints and our bones and everything else after Lydia has spoken about our muscles. Yeah, they all go together. And if movement is something that we value, being able to still be mobile, enjoy our lives, then this is probably very essential, yeah, how we value and the quality of our life. So over to you, Prof Tay.
Thank you, Maleena. And before I start, I'm just wondering whether we have a pointer. It's not on this thing, is it, Ben? Is there?
The one at the top. This is.
Oh, that's a
pointer,
pointer.
yeah.
Oh, okay.
But it would be probably.
Yeah.
Yeah.
Does it show? That's quite bright. Okay. Maybe if I stand, I feel a bit more at ease. First, let me thank CD and of course the CEO of Head Foundation, Chanda, for creating this opportunity for us to present some of our thoughts and experience. And also I want to thank Maleena for twisting my arm to present it, because over the years, I find it easier and easier when everyone and anyone asks me to talk. I asked my son, who's an orthopedic surgeon as well. I said, Darren, do you have a talk on this topic? Can I borrow it? For this talk, I had to sit beside Maleena and said, you take the notes, okay? And then we Googled together what we need to present for this talk. Yeah, and we came upon this idea of talking about some of the more novel solutions to the aging knee. But before I do that, can I say how glad I am to be able to come here? Because over the last 2 years, my natural automatic mode is Zoom. I don't see anyone, I only hear. And most times I leave it on and I spend doing some other thing, most of the time on my phone. So that has been the normal practice. So I'm so glad to be able to come to a real audience. And not only that, an audience that more of you are unmasked than masked. So I'm extremely happy, and especially happy in this audience to meet up with Linda Zhong, Professor Linda Zhong, because we're doing a study on 𝗙𝗏, which is also for aging. And we hope that with our study, one day, we will be able to introduce, like we have introduced acupuncture in modern medicine. You can go to SGH today and you say, I want acupuncture. And you say, you mean I can get acupuncture in SGH? I say, yeah, you go up to level 2, you can get it. And it's a real acupuncturist, one from Beijing University and one from Linda's alumnus is working as a acupuncturist and in SGH in the service, the pain service. So I'm glad because Linda, as a professor in TCM and NTU, is working on this topic. So maybe, hopefully in a year, maybe a little longer, we will find that 𝗙𝗏 is available in Singapore General Hospital as well. And then you can use your MediSave. You can use your government subsidy, and you can use insurance too. And that's what we hope for, right, CD? The other thing I wanted to share with you, I Googled this, and I Googled this before, but I thought I'll share this with you. So, in biblical times, well, some of you read the Bible, how old do you think Adam was before he died? Can I ask one of you? Maybe this young lady. How old do you think Adam was? You know, Adam and Eve, the first two. Do you know? I can take a photo of you. Maleena, can you guess?
I know Abraham was very old.
Adam was 930 years old. Seth, I don't know who he is, 912. Enos, 905. Canaan, this one I recognize, was 910. Mahalalel was 895. Jared, 962. Enoch, 365. He must be, oh, he was not out. But they were all about 900 years old. And then I Google again, what's the lifespan today? You're living with good, like if you listen to Lydia and live that kind of life that she promotes. It is suggested that the maximum human lifespan should be around 125 years. So in another 50 years, most of you should be still around, if not 100, yeah. 125 is the target today. So take the 125. Well, what we may not have enough food to supply all of us, 125. We'll be short of food. But the good news is Singapore is the first country in the world to manufacture proteins from cells. First in the world. Fantastic, isn't it? For a small country like Singapore to commercialize proteins from a cell. Yeah. So what am I going to leave you with today? Let me see. Okay. So the point I would try to make is, would it be nice, instead of going to a surgeon like me and say, doctor, the family medicine say it's too late for drugs, too late for physio, too late for acupuncture, too late for TCM, but you need a joint replacement. That's major surgery. That's about, in most people's hand, an hour and a half to 2 hour surgery. Yeah. But would it be nice if you just give you a tablet or an injection and then you say, go home, you know, the next 1 year, you don't have to see me. But there's a distinct possibility that injectables, at least the way we are going, injectables using cell therapy. I don't like to use the word stem cell, because when you use stem cell, they think of, what's that ship? Dolly the ship.
Dolly.
Yeah, Dolly the ship. When we say stem cell, pluripotential cells with all the potential to even develop an organism of its own. Can you imagine if we had 10 Hitlers in this country? Oh, that'd be worse than a Biden and Putin put together, isn't it? Yeah, so gladly we don't have that capability yet, or at least if we have that capability, we can regulate it so we don't have the Hitlers of today. Yeah, but not only that, you know, we use stem cells exactly like we do in marrow transplant for leukemic patients. One of the major problems is the cells itself overcome the host. You call it the graft host problem. The graft overtakes and kills the host. The graft becomes like a cancer. Then of course there's cancer. So that's all the emotional and the ethical aspects of medicine that if we are not careful, we tread into very dangerous grounds. But then if we use your own cells and we don't change it too much, that would be quite safe, isn't it? So that's what I hope to leave you today. So we know that there are risk factors for OA, and I think the biggest risk actually is this one here, aging. But if Adam can live up to 900, we should be considered infant today. We're babies now, right? Or even if we took 125, which is the real potential for today, that means correctly speaking, everything being right, today you can live up to 125. Then if we can prevent this, then at 100, you should be the equivalent of today's 50. Or thereabouts, sir. Wouldn't that be nice? Yeah. So, Lydia gave an estimate of people with sarcopenia and people with fall potential. But this is the worldwide burden for osteoarthritis, just in the knee. 654 million. That's half the population of China having painful knees. Isn't it terrible? Half the population of India, maybe 2/3 the population in Indonesia, all having painful knees, if you put them all together. So that's a big burden. Yeah. Oh, doesn't work. Can I go on to the next slide? For some reason, and we still can't explain completely, the proportion of females having osteoarthritis is larger than that of a male. And if I would give you a figure in Singapore, it's about 8:1. So for every 8 ladies here that have osteoarthritis in the knee, there will only just be 1 man with painful knees. So if I have a choice for this reason, I'd rather be a man. Yeah. Yes. So what I'm planning to go through with you today is to show you that apart from having a big operation for the total knee, oh, I think I lost the, there's no laser. It's okay. I will do it without the laser. It's nutraceutics. And why nutraceutics? Because nutraceutics are not pharmaceutics, right? Pharmaceutics are the things that you have pethidine, you have cocaine, you have, and then you go to Thailand, you can have, what is this drug? Cannabis, yes, cannabis. Cannabis is also a useful drug in pain as well. Yeah. And it may be considered a nutraceutic because it's actually vegetable, right? So we have a vegetable proposition here. But there are some nutraceutics that we now know that patients will ask for. The scientists will tell that there's no evidence. But then the patients are the one that matters, right? And we'll come to that. And then there are topicals. And topicals are very good for Asians. From young, when I twist my ankle, my father will bring me to TCM actually, most times. And they'll give me things to apply, things to wrap around. And topicals are more used in musculoskeletal than actual surgery. And what I hope to leave you all with is this topic on injectables that you bring home, that one day you push a doctor, why don't you give it to me? Because there's a regulation in Singapore against it, which is slightly behind the regulation in the States and in Europe. And they're better off that the regulation allows them to do this. Huh? Oh, and this one can work too, huh? Oh, that's right. Yeah, this works better. So this is it. This is really in the area of Maleena. But every time I show a product, it says, this one rubbish. So in food, there's a lot of rubbish. But I hope one day there's something. But you hear from the doctors, glucosamine, right? And collagen. And why glucosamine and collagen? Well, you say, why there's so many types of vegetables in the garden. Why not tapioca or why not sweet potato? Why you come with glucosamine is from usually the cup of the hand, and collagen is from the skin. It's because glucosamine and collagen are actually the building blocks of cartilage, which is the reason why you have joints, the smoother of the joints. It's composed of collagen a lot and glucosamine. So there are articles that support, there's some evidence, meta-analysis here on glucosamine and also on collagen. But you know, for the ladies, there's one added benefit. Your doctor says, glucosamine or collagen? If I were a lady, I would say collagen. And you know why? It's good for the skin. Yeah. It makes you young and beautiful. Yeah. And that's what it's all about today, isn't it? To prevent you from aging. Yeah. But then we have topicals. And if there's one topical I want to leave you with, of course, you have things like tiger balm as well. I don't put it in, but these are actually drugs, you know, topicals. And say, you know, the Fostem gel is actually diclofenac in it. And Voltaren gel, of course, is, the Fostem is ketoprofen. And Voltaren is diclofenac. But there's one, and then, of course, you have the koyo, the plaster. And this is very good. As I said, you know, as Chinese and as Asians, we are brought up with koyo and the balm. Yeah, balm. Yeah, tiger balm. I was brought up with tiger balm. But this is one thing. If you have time, I would like you to write it down. 𝗙𝗂𝘂𝗁𝗔, 𝗙𝗂𝘂𝘁. And you look at it, it's actually innocuous nanoparticles. It was originally, and it's being used now, to put drugs in it, and you can put it in the eye, nanoparticles. And they did a study with NSAIDs, which is Celebrex, which some of you may know, with a nanoparticle and diclofenac inside the particle. And they found that the nanoparticle works just as well. Just the nanoparticle, just the particle is without any drugs. And the reason they work is because it is attracted by water. So there's in the joint, there's water. Always there's some joint fluid. It's attracted in, it flows in, and it acts like what we're going to talk next, hyaluronic acid. Some people, the Chinese call it yu. Yeah, oil in the knee. It acts as a shock absorber and a lubricant. So that's a drug that you may want to try because it's a mechanical property really than chemical property, right? Oh, something I do that. All right.
Never mind. Ben?
Thanks.
Yeah,
okay. Now, this is where I want to leave the message with you. And we'll go through some of the injectables. Because if you come to my clinic, I'm about 20% injecting. I went to a conference and I spoke to this lady who was from the orthopedic department, 𝗙𝗯𝘂𝘂𝘁𝗂𝘁, from famous orthopedic department, Harvard University, MGH, Massachusetts General Hospital. So I said, Dr. Joan, you're in the orthopedic department. He said, how much time do you spend as an orthopedic surgeon operating, and how much time do you spend giving injections? And what she told me, I almost dropped off the chair because she said, I don't go to the operating theater at all. All I do is give injections. So there is in populations that are large, they can have departments that can subspecialize. Doctors that do nothing but just inject. They inject for soft tissue injuries, definitely, and they inject for osteoarthritis of the knees. And so we want to talk about what are injectables that are available for osteoarthritis of the knee. And hopefully this is what you need. I am preaching to you today with a message that hopefully one of you was scientists here or together with us will discover the cell therapy or molecule that we can just inject and you don't have to go to an orthopedic surgeon anymore. It's just like, you remember whenever you have heart attack, you say, wow, finish, go and see a heart doctor, sure open up and, you know, they got all these pumps and all that. You don't know whether you wake up or not. But now they just balloon you and they put a tube in and they balloon it, and they put a stent, and then the same day you go home or the next day. Isn't it wonderful? If we can make, they make cardiac surgeons lose 50% of their revenue. So that's the idea. We hope we will reduce the revenue of the orthopedic surgeon by 52%. Yeah, a little bit better with these injectables. So this, oh, how do I go back? Is there a back? Oh, there is a back. Excuse me.
Yeah, this is back.
Back. Okay. So clearly one of the earliest injection we used was steroid injection. But you know, steroid injection is a little dangerous because it encourages infection, reduces immunity. But not only that, steroid injection also causes, if you do it long term, it causes osteoporosis. It causes a buffalo hump. It causes cataract. So there are a lot of side effects with. On the other hand, I wanted to introduce this to Lydia because, you know, all the muscle builder. If you and I do the same exercise as the muscle builder, you never get to the size of the muscle man. And the reason why is because they inject anabolic steroids. Most of them, if not all of them. I suspect all of them, you know, for a period of time. And just before the event, they will stop maybe 3 months, let it wash out. Yeah. But you cannot build that huge muscles, you know, that you see, that well defined 100 packs or whatever it is, without anabolic steroids. So I was saying anabolic steroid is actually very useful in sarcopenia. Yeah, I give it to, and it gives you a well-being, a sense of well-being too. So the ladies usually, because somehow they get osteoporosis, they also get osteopenia. Don't know why, they suffer more than men. Yeah, if they have. But this steroid is different. This is the anabolic steroid. It's anabolic, which is built. But this steroids that we inject in the knee is a catabolic steroids, which reduces inflammation, very strong anti-inflammatory. Therefore, even if I give you a tablet and you're pain in the knee, the pain will go away because part of the pain is due to inflammation. Then, of course, the second one is hyaluronic acid, and that's commonly used. And that's both you can use in Singapore. This one, the government won't come after the doctor or the insurance. You can use that. But hyaluronic acid actually acts as a mechanical thing more than a chemical thing. It acts like a shock absorber and a lubricant. It's supposed to mimic the joint fluid, hyaluronic acid. Yeah. More recently, we are allowed to use platelet-rich plasma. And we know platelet-rich plasma, we infuse platelet and we use autologous platelet. That means we use a donor. And it's safe enough to put in the vein. So definitely, if you use the same platelet, it should be safe enough the knee, isn't it? Because you put it in the vein to prevent bleeding, to reduce bleeding, to get your bleeding mechanisms back to normal. So we use platelet, yeah. But in our patients, we use their own platelet. We take it from the vein, we spin it up and concentrate it. So logically, it should be even safer, right? You have here patients that are bleeding, we use donor platelets. Here we have OA knees, we use your own platelets. We call it autologous platelet. So, and they work by reducing inflammation. So we used to teach medical students that, you know, rheumatoid means inflamed knee. Osteoarthritis means mechanical degeneration. The two are different. But now we know actually the two do cross a bit. There is an inflammatory component. Otherwise, why in osteoarthritis you get huge swelling, you know, effusion, water in the knee? It's because of inflammation. And so the platelet is an strong anti-inflammatory agent. Plus, it's also a strong growth. It's very strong in repair. It enhances repair. So we hope that the repair not only remains only in soft tissue, but also in cartilage as well. So that's the basis of platelet-rich plasma. And now we find that if you add hyaluronic acid, which is mechanical, and you put the platelet-rich plasma, and we're doing a study now with actually 𝗙𝗂𝘂𝗁, who's my colleague's daughter, we find that if we add the PRP to hyaluronic acid, the effect is even better than just hyaluronic acid itself. So there is a basis for, and then lately coming up from Italy and from Korea is this chemical called polynucleotide, and it's obtained in Italy from trout and Korea from salmon, or vice versa. I don't know which of this, but it has almost the same action as PRP and hyaluronic. So it has a mechanical effect and a biological effect, which is anti-inflammatory and repair. So you will probably hear more of this in due course because it's just entered the market. I think they just got HSA approval, but it's not in that scheme of things in SGH. SGH, you have to always put it in the drug list, you know, then they can charge them. Singapore, nothing is free, right? I remember this as a young man when 𝗙𝗂𝘂𝗁𝗂 said, in Singapore, nothing is free. Car park must pay. Throw papers on the ground must pay. Spit also must pay. Don't flush the toilet also must pay. Nothing is free, right? And everything you have to pay for it. Good. So this is platelet-rich plasma. We take it from the vein, blood, your own blood, and we spin it, we centrifuge it actually. And one of my friends now, very smart guy from my school, he actually did aeronautical engineering. Then he came back, he broke bond, he went back to Canada and became a doctor. And now he's got because when you centrifuge, there's heat. And there's heat, some of the cells will be damaged. So he has this, I don't know what term he used, by chemical Texas, he pushes the platelets to one side and you have a concentrated platelet. So plasma-rich platelet, you're going to hear more of this in your therapy. I went too far. The one that I'm going to leave you home today is this one, cell therapy. In other contexts, they call it stem cell, but when you call it stem cell, the Ministry of Health will send their inspector straight to your clinic, and then you'll be in trouble. So we call it stem therapy, and sometimes we call it marrow concentrate, but it's actually cells. If you call it stem cell, then they think of what's that ship again? Dolly the ship. Yeah. So that is the ethical issue that we face when we go into what we call pluripotential cells. That means cells that have potential to divide into other organisms. But apart from that, I just want to quickly tell you that we have products of cells, and this includes exosomes, which is used a lot in the dentistry to grow bone, and autologous protein solution, which is a chemical thing. So I won't talk about products of cells. We inject these two and their results. But I want to talk a little bit more of cell therapy and we finish. And it is obtained largely from two sources, bone marrow, three sources. We should actually put this all in one line. Otherwise, you think this is part of bone marrow. So bone marrow, microfermented fat, we can actually aspirate the fat and spin it and get the pluripotential cell. Let's not call it stem cells, cells with potential. And this one is definitely not allowed. Although in Malaysia, they go to the ONG department, the women department, then they deliver the baby and they collect the placenta, and then they take the embryonal cells here, or from the cord, or from the placenta, then they concentrate it. And they do it in Singapore actually, but don't tell anyone I'm telling you this, okay? Then they will put it in a valve, then you arrange a courier taxi for you, and you ride across the causeway, and they cut. They would go there in 1 hour instead of 2 hours. Then you go to a clinic, and then the doctor inject it in for you. But then you pay the doctor $3,000. But in Singapore, I think $25 enough. Yeah, but that's regulation. And I think Singapore government is right, because really when you deal with embryonic cells, very primitive cells, you really don't know what can happen, right? The story is not all out yet. I mean, we know Dolly, the sheep never lived to a mature age, died early. Yeah. But you know there's also graft versus host. So I think this is out. I put it there so that you know it's out. It's not available in Singapore. But there are people here, factories here that go to Malaysia and Philippines, and this is business for them. Yeah. But this is available in Singapore, and we are doing a study because it is also regulated by, Singapore is very heavily regulated, and maybe it's good. Don't know, in a long time, I may be wrong. I think they're old-fashioned, but maybe they know something that, well, maybe they got into something that is right. Sometimes by chance they get it right, right? But here it is, bone marrow. We're going to start this study soon. It's a study started in NUHS already by James Hui on marrow, where instead of concentrating and injecting it, they passage it, they multiply it so that it's, because you know, when you take your marrow cells, when you have osteoarthritis, you're not young, 13 years old. You are like 60 years old. So you can expect the cells are also old, right? So you inject old cells into old knees, it must be still old knees, right? So, but they hope that when they passage it, they concentrate it, the cells are more active and more potential. So this is what I want to leave with you. And hopefully the story is not the end. Oh, something. Next one, please. Yeah. Then there are other things like truncatus. And I want to leave you with one more thing. The next slide, please. And then I'm going to end this talk. Right? Where's my biceps? So I have this machine in SGH. So this is now slightly commercial. Okay, so put it in and let it come out. A machine that's developed by NUHS by Emily, are you a doctor? Say Emily, I got her right. Lydia's friend.
Ruby.
Ruby. Are you a doctor? No. But there is C.N. Lee, a cardiac surgeon in NUH, and he's got this scientist called Alfredo, and they developed this machine called biceps. If you can Google it, B-I-X, instead of C-E-P-S, is X-E-P-S. And the biceps machine actually creates ATP. And actually, when I was asking Lydia, I was hoping she would say, oh yeah, there's a machine, actually, you put your leg in for 10 minutes twice a week, and you create this powerhouse. ATP, when I learned biochemistry as a medical student, is the powerhouse in the cell, produce all the energy. And biceps actually produces ATP by electromagnetic means. And it has some way of relieving pain as well by increasing. After all, when we say you have pain in the knee, we say go to physiotherapy. Physiotherapy strengthens your muscles. Your muscles take off some of the pressures in the joint, and that's how you get some relief of the pain. So I think in the same way, when they improve this biceps machine. So that's what I want to leave you with. But the main message I want you to leave you with is, one day soon, the cell is going to make a difference to osteoarthritis in the knee. And one day soon, the orthopedic surgeon will lose, we said 52%, right? Oh, thank you.
Thank you, Prof Tay, for that very inspiring talk. We're all hoping to age without too much pain in our knees.
And you can live up to 900.
That one I don't know. As a food scientist, I don't think we have enough food to feed the entire planet. We're all going to not die within the time frame we're meant to. I invite the audience as well as an online audience to ask any questions or to clarify if you have. Don't be shy.
Maybe I start with a question from the Zoom audience.
Thank you,
I believe this is a question for Lydia. What is the recommended walking aid to use? A lot of what I see in the market are not stable at all.
Actually, if you really do need a walking aid, right, something should be reassessed, you know. A lot of the times for us, we shouldn't be requiring one unless you're actually moving on a very uneven terrain. So if you are unbalanced, then the first thing is to assess why you are unbalanced. And the second thing would be then to see, as you said, the appropriate walking aid. I know that for sure, right? Any of my old folks that come and show me their umbrella, I feel like if I was a strong man like everybody else, I would have broke it and threw it away. But, you know, umbrellas are really a no-no. But they always tell me that, oh, these days umbrellas are fantastic. They can hold your weight. So they say, but a proper walking stick to begin with can be good enough. It's sturdy. The only things that really has to be looked at when you're using a walking aid is actually, is it an appropriate height? And is the bunk that actually drips onto the floor, is it actually worn out or not? So these are your, like, you know, basic 101 when you look at the walking aid. Other than that, the prescription usually comes with the physiotherapist, and usually the walking aids are actually synonymous with people with neurodegenerative disorders like Parkinson's, like stroke patients, like people with a fractured hip. Then we will see which one creates a better balance with gravity, creation of a tripod that is stable for them for the time being. But if you're just a normal person like me and you know you think that the terrain requires a walking aid, then a walking stick is actually good enough. It shouldn't be anything further than that. Yeah.
Thanks,
I hope
Lydia.
that helps.
Ben, I can't see Lydia on this screen, and I'm going to have to crane my old aging neck to see. Is it possible to have it? Otherwise, I can sit just opposite. No, it says no source found. ZV.
Never mind, Maleena, you don't have to see me lah.
Yeah.
You see me every day already, ma.
Can.
Don't crane your neck. Later have to put 𝗂𝗂𝘂𝗁 like Prof say, you know.
Yeah.
You don't talk faster, you know.
Go for massage, huh?
Yeah. Finger massage. Okay, let's go.
Any other questions, CD, or from the audience?
Yes, there's another question from the online audience. I believe this is for Prof Tay. What are the costs of some of these treatment or medical consultation you talk about just now?
Oh, okay. That's interesting because, you know, it just shows what happens when you regulate. There's a cost, right? So we were dealing directly with vendor and clinic and then patients. So we say, what's the price you cost us if we gave PRP? And it was about 200 something. What if it's PRP and 𝗙𝗂𝘂𝗁 was about 350? Then the hospital said, Dr. Tay and his mate, they are illegal. They go directly to vendors and then to patients. You know, everything else must have a code, must have a price, and must have a document on how it's done. So now we have a code. We have how it's done, because now instead of me asking I have, fortunately for me, because I'm old enough, so they give me an assistant to help me. So they take the blood for me. Otherwise, the last time I took blood was when I was a houseman more than 50 years ago. I don't think anyone wants me to do that. So we do that, and it's 𝗙𝗃50 and 𝗙𝗃𝘂𝘁. Then when we regulate it and we code it and we said now the nurses can do it, which is quite good for me actually. I just send it there and nurses bring back the vial. I just inject. But it's $700. And then yesterday this Indonesian patient said, "You told me $700. My friend came and he says bill $700. My bill today is $1,000. Why is that so?" So actually my answer is I really don't know, because it's an evolving thing, you know, with regulation changes and cost. But roughly if you have $500 in your pocket, I think you can go for it. But don't be shocked if it comes out $1,000. And I think that's a mistake, man. Probably a mistake. Yeah, it should be between, 700 should be, yeah, enough. Is that expensive? Yeah, wait until I get Lydia to come in with me to give 𝗙𝗃𝗃𝗃𝗃𝗃 and biceps for sarcopenia. Yeah.
For all of you to know, Prof was actually my consultant and I was his house officer. That's how young I am. I'm just kidding. Okay. Actually, I just want to read off a question that was actually online. It said, does BMI need to be modified for elders in view of natural loss of bone mass? Can I just rectify that, that perception? Old folks do not usually just shrink, okay? In fact, right, if you lose more than 2 centimeters of your natural height at peak, which is about 25 to 30 years old, you are actually at risk of osteoporosis. So an osteoporosis is not a natural thing at all, okay? It is actually a disease. Natural is if your hair grows gray, I'm just kidding. But certainly when you're growing shorter, it's either you are actually losing vertebral mass, which is abnormal, or you are actually losing it so badly that, you know, the spine becomes crooked, and that shrinks you. So please do not walk away thinking that we all shrink in height. I am not going to be a dwarf by the time I'm 90, okay? Enjoying, so the next the next part of that question was, the person enjoy long walks but have been urged to exercise less so as to gain more weight to be in an ideal BMI range. Maleena, maybe this one you help me out, but I really felt that exercises are important. To stop exercising so that you can get fatter sounds a bit weird. Maybe if you just snack and use that excuse to eat more potato chips on the sofa like I do, that is for sure going to make you fatter. Trust me, okay? Yeah.
Thanks, Lydia. Well, beyond the getting fat, I think there is a whole influence on mood when you exercise, just as food or sugar intake and everything else. Last week, we had Dr. 𝗙𝗃𝗃𝗃𝗃, and he runs 20 kilometers daily, right?
In my dreams.
Gets up at 4 and he hits the rubber by 5 and he's done, you know, by 6 something 7. So I think there is also a component for that, for mood regulation, that you feel actually good and, you know, top of the world. You eat better, you sleep better, the whole cycle kicks in, right? So exercise definitely helps. And I know that if my knees hurt, I can't do things that I really like very much, like dancing, swimming, not so much the actual swimming itself, but when you have to do the plunge in, that you're springing off, and that's extremely painful. So it's a lot of things that are compromised if you can't do it. And that in itself is your quality of life, right, as you age. And this is a question, I don't know whether it's for Prof Tay or Lydia, maybe something to be said about women, in the sense that post-menopause, all the changes, hormonal changes, the frailty. Lydia, would you like to say something about that?
I don't think that we should use that as any kind of excuse in that sense. I think that there are many exercises that do not kill our joints. I mean, as I keep telling everyone, and I think it's ad nauseum now that everyone knows and can see that I'm plump. So I certainly will need Prof Tay's injections sooner or later. But having said that, right, menopause is not something that anyone looks forward to. But as I said, joint-wise, there are many exercises that protects the joint. resistance exercise to preserve the muscles do not kill the joints. As I said, the uncle auntie gym tonic thingy, that certainly are for people who have got creaky joints. So I really do want to support the fact that, number one, exercises in safe forms can be done, and that we shouldn't listen to some of those things that says that you shouldn't exercise. In fact, I just came off a very comprehensive European societies conference, and all I could take home was that the exercises have to be progressive and has to be resistance and has to be increasing. And I keep thinking, oh my word, all I want to do is just lie on my couch. So if you imagine that this is EUGMS, Geriatric Society all over the world, telling you to do progressive resistance exercises, there's nothing to say that please pause because you're menopause, please pause because you're getting shorter, or please pause because you're getting thinner. It didn't say that at all. I hope that was loud and clear. Sorry.
Thanks, Lydia. Now you see why when I need therapy, I go and see Lydia. Yeah, I just barge into her office, and I haven't heard 𝗙𝗂𝗂𝗁𝘂 in a long time, so I'm very happy that she has used it today. It jogs my memory. Any other questions from the online audience for our speakers today, or our audience here?
I have a question since Maleena is sitting there. We don't want
I'm going to stand because my watch told me to stand.
Is that opportunity to ask, because I happen to know Maleena has been, very active and doing a lot of different exercises. So, specifically, what kind of exercise or physical activities are good for what ages, right? I know you do tennis, you do dancing, you swim, you do yoga as well, and not just for the bones and the muscles, right? What about the lungs and the heart, right? Is there any kind of a very scientific recommendation of what type of exercise are good for different old ages?
Well, maybe I can invite our Ben. So the little anecdote here is 10 years ago, I go to, I think I won't name the company, okay, it's a gym. And Ben was actually my body jam teacher. It's one of these choreography things, right? And I think, so it's 10 years later, and obviously, the cardiac health of things, plus hormonal changes is just going to affect us. But if first of all, I think for any exercise, you should actually enjoy it. Right? It's not sustainable if you're forcing yourself. Same with the diets, the crazy diets that don't make sense. You're just not going to enjoy it, and you're just going to cheat after that. So you're going to be yo-yoing. And same, if you want to scare somebody half to death, someone who smokes 2 packs a day, and say, you better stop or you're going to die, it's very unlikely that you're going to change. So lifestyle changes, whether it's exercise or sleep or food, has to come from some form of internal motivation. And quite often, if it's pleasurable, something that you can sustain and continue, that would be good. In exercise itself, I'm no big expert. There are much more eminent people who do research on that and in all the big universities. But essentially, if we were to sort of just crystallize it, something you enjoy, something you can sustain, something that then helps you increase your what we call the cardiac response, right? You're going to actually be able to do something. Aerobics and things like that were essentially designed for that. So you're going to be huffing and puffing, and it's a little bit tough. Then your flexibility as well. So things like yoga and all that. Pilates would be your core strength, because backache is the big headache of the century. At least 60 to 70% of the population suffer from it. So if you've got your back and your abs that are strong, then it's less likely that you're going to get these problems. And any resistance training, so that would be with weights or when I brush my teeth, I just do squats, right? Because it's so boring to be brushing your teeth. You have to do something about it. So, and you know, integrate it into your life. If you can't spend a whole hour doing a run or yoga or swim, or you've missed that slot at the gym because you had to do some report, right? Then you integrate it into your life by doing 10 minutes of crunches or sit-ups or burpees or anything like that. You can actually either dedicate time to it or integrate it into your life. I know CD is an avid runner and he tracks all that with his apps. So there are people who are very techie and like to do that. I do not do that because I prefer to just see whether I can fit into my clothes, whether, you know, these are all simple indicators, right? Yeah.
Maleena, you know what I do? I actually shake my Fitbit rather than run with it. So, so that's how good I am. You know, I thought maybe just some really cheeky person, and I read out the question because this will probably end the session really nicely. It asks, how important is sexual activity among men and women at such age? I don't know which age you're talking about, huh? Does good sex provide the best therapy? Seriously, it is on the screen. You know, Ben, if you could just pull out that question, you know, you'll be amazed at what people are asking us now. We have become sex therapists here, but let's put on a straight face and give you that answer. I think any kind of activity that makes your mind happy, great way to go, even if you die doing it. The second thing is, if you have good sex, it means that you have got good enough, you should have enough, what we call meds, okay, to climb up 2 flights of steps. So if you're huffing and puffing by first flight, please do a lot more exercise before you have sex. And the third thing is, it has a lot of flexibility. So if there are 4 well illustrated ways that Maleena has talked about exercises: aerobic, resistance, balance, and flexibility, you are probably going for the aerobic and flexibility when you're doing sex. I hope that helps, whoever asked this.
We had a similar question last week, but it was addressed to men's sexual health, and that's when I came charging in and said, what about the women? 50% of the
So now we got both of it now.
I think so. And I think your answer is straight to the point.
Oh, I'm only the sex therapist here, you know.
No beating about the bush with Lydia. I will just, I think, CD, would you think that I could sort of close now and have a little synthesis, or are there more questions?
Well, there's no more question from the audience. Why don't you summarize and close?
I don't know about being able to summarize, but I think it is a topic that not just intrigues us, but sometimes we're a little bit fearful if we're caregivers for aging parents or an aunt, and for ourselves. And the less burden we leave for our children, the better. Also, that's always at the back of our minds. If, you know, I were to think about physical health per se, I would also look at all the other components: mental health, emotional health. And last week we approached the topic when the gentleman asked about sexual health. Intimacy, you know, loneliness is one of the things that is quite awful when people are not supported, you know, with loving family and friends, and that alone is a killer. In the UK, 60% of cause of death, indirect, is loneliness, because they're not cared for, not looked after, and therefore feel that, you know, disconnection with people. So in our audience today, another anecdote, I have Dr. Chan Wing Cheong, and he's going to roll his eyes at me. So Wing Cheong and I went to school a long time ago. I think we were maybe 16, 17 years old. Huh? So the aging process we can see now, we all have a little bit changed, less hair, you know, hopefully wiser. And Wing Cheong, I came to meet again when I was working at Alexandra Hospital, simply because I think, I don't know how I found you or you found me, but we ended up having lunch. And he said what he was doing at NUS at the time for protection of the elderly He did law as a subject, and I think, it's very laudable to be doing that because there is elder abuse. And these are topics we didn't include into the talk because we wanted to talk about good news, but this is sort of like scary news. But being aware of it is important, and calling it out when it happens and supporting those who need that help. And through time, I think he asked me if I would do work with the elderly at an association, and I did. So there I was doing yoga exercises and stretches on a Friday morning, taking time off work. Then I realized it wasn't feasible because I needed to save my leave to go and see my children living overseas. But then it transformed to mentoring youth and helping them out, the underprivileged. But that was a Saturday, so that was all right when I wasn't working. But to say that your friends from way back and people that you know, whilst you age, there's a common understanding that, we know one another for so long that almost anything is possible. So reach out to your old friends, make new friends for sure, because if you're going to live long, you need a lot of young people who age with you because they're all going to die off anyway. So that's the scary part. And I will turn my focus to Lydia as we wrap up. Not that I'm trying to, praise or say anything that she would definitely be embarrassed, but Lydia, very kindly, when my father was, at the end of his life, he actually wanted to be at home. One day, he wasn't able to ingest anything anymore. And therefore, I was at the pharmacy trying to buy medicines, and I couldn't get them. And they said, all right, the suppositories would work. And I went there and I queued for a long time in spite of being hospital staff and couldn't get it. So I was quite dejected, went to the car park, about to get into my car and just go back and see my mum and dad and announce the not so good news. Lydia comes just there in the car park and she says, what's wrong with you? And I said, this happened. So she sends me back up and she waits with me at the pharmacy and she gets it. And she comes with me home. She takes care of Dad. And then she says, I'm not done. I need to look after your mum. Auntie, are you okay? So this is the complete care when you talk about even elderly couples, right? She's a very sweet, dear person. She can be very fierce. But so this is the personal story of Lydia, and I'm very grateful that she was able to give the talk today. And for Prof Tay, another very sweet and kind friend, but I cannot say, so I don't say. But their emails are available. Do continue to ask questions or any comments that you may wish to have. And I thank the Head Foundation. I thank CD and Ben as well, and 𝗙𝗂𝘂𝘁 who's been helping out with all the admin work, because I'm very bad with that. And thank you for being on top of things and making all this happen. So I'll give the floor back to CD.
Thank you, Maleena, for the very good ending story. Also, thank you, Lydia, as well as Prof Tay, for your sharing. We certainly learned a lot about, I think today is a lot about the sciences of aging. The title of our series is Art, Science, and Good News of Aging. Right, so as you know, this is the second part of a series of 5 talks. Next week, not next week, 2 weeks from now, also on the Wednesday, we will have Professor Wong Pok Kam and Ms. Lee Fong Ming to talk about something quite different, right? Not the mental or the physical sides of aging, but about how to get yourself prepared for aging, right? Not only ourselves, but also the family members, the financial aspect of things, and other kinds of arrangement. What are the tools available out there to help us better prepare, along our life, so that we age with a peace of mind. So please, if you're interested, sign up as you've done, and also you find this useful and informative, please also invite your friend to register as well. So thank you, every one of you who came and those who are online.